Hello, I'm Dr. Jonathan Kay, Professor of Medicine and Director of Clinical Research in the Division of Rheumatology at UMASS Memorial Medical Center and the University of Massachusetts Medical School, both in Worcester, Massachusetts. Welcome to Rheumatoid Arthritis Quality in the Value-Based Care Environment, evidence behind the rheumatoid arthritis quality measures. In this program, I'm going to discuss the PQRS measures relevant to rheumatoid arthritis and try to place them in a clinical context whereby there's a bit of understanding, perhaps, as to why these are appropriate to assess in patients and what the consequences might be if these are not assessed. The Centers for Medicare and Medicaid Services have put together Physician Quality Reporting System measures, or PQRS measures, relevant to a number of diseases. There are several measures that are specific to rheumatoid arthritis, and we'll go through these in the next several minutes. A quality measure is a way of assessing whether an action has been done to address a quality indicator or something that is measurable which reflects the beneficial treatment that results in a positive outcome of a patient with a given disease. The first PQRS measure for rheumatoid arthritis, number 108, relates to DMARD therapy. In this one, the percentage of patients aged 18 years and older who were diagnosed with rheumatoid arthritis and were prescribed, dispensed, or administered at least one ambulatory prescription for a DMARD is assessed. Now, this is a relatively straightforward assessment since it is well documented that patients with rheumatoid arthritis should be treated with a disease-modifying antirheumatic drug as early on in the course of disease as possible. The consequence of not treating a patient with active rheumatoid arthritis with a DMARD is progression of the disease with structural damage, cartilage and bone erosion, and functional disability, permanent structural functional disability, and decreased quality of life. The DMARDs that are eligible for this PQRS measure are quite broad, and as long as a patient is being treated with a medication more than a nonsteroidal anti-inflammatory drug, this measure is satisfied. The next PQRS measure, number 176, relates to tuberculosis screening. It has been demonstrated clearly that TNF inhibitors and several other biological therapies increase the potential for reactivation of latent tuberculosis. Thus, it is important to identify patients who are to be treated with a biological DMARD and perhaps other DMARDs who have latent tuberculosis so that that can be treated before initiating therapy with the agent that might increase the risk of reactivation tuberculosis. This measure is very reasonable, and it is quite reasonable in clinical practice to check a PPD or an interferon gamma release assay to assess whether or not a patient has latent tuberculosis and to treat that if present. The next PQRS measure, number 177, is that related to periodic assessment of disease activity. Now, when we treat a patient with rheumatoid arthritis to assess whether the patient is responding to treatment or not, one should examine the patient's joints to look to see whether there's a decrease in the number of swollen and tender joints, talk to the patient and ask them how they're feeling, and also assess laboratory measures of the acute phase response, such as an erythrocyte sedimentation rate or a C-reactive protein. In this measure, the percentage of patients aged 18 years and older with a diagnosis of rheumatoid arthritis who have an assessment and classification of disease activity within 12 months is calculated. Assessments of disease activity include the DAS or the DAS-28, the disease activity score, using either a full joint count or a 28 joint count, the clinical disease activity index, the CDI, or the simplified disease activity index, the SDI. So measuring any one of these disease activity measures can classify patients into low, moderate, or high disease activity or remission. In addition to measuring disease activity, it's important to assess functional status of a patient, and that is the subject of PQRS measure number 178. In this measure, the percentage of patients aged 18 years and older with a diagnosis of rheumatoid arthritis for whom a functional status assessment was performed at least once within 12 months is calculated. The functional status of a patient can be assessed in any number of ways. Ted Pincus has developed the multidimensional health assessment questionnaire, which can be given to patients in the waiting room and easily scored by the rheumatologist in the examination room within a matter of seconds. The Stanford Health Assessment Questionnaire, either the original version or the revised version number 2, is a bit more complex to score, but again can be administered, and there are online scoring systems that make this relatively easy to record and calculate a score. The PROMIS system is developing physical function computerized adaptive tests where patients answer a question on a computer and that response generates other questions that are relevant to the patient's initial response. This has also generated 10-item and 20-item questionnaires, each of which can be used to assess functional status. But it's important to quantitate functional status, at least by asking the patient questions related to their physical ability or inability. In addition to assessing functional status and disease activity, it's important to assess and classify patients regarding disease prognosis, and this is the subject of PQRS measure number 179. In this measure, the percentage of patients aged 18 years and older with a diagnosis of rheumatoid arthritis who have an assessment and classification of disease prognosis at least once within 12 months is calculated. And disease prognosis is a bit more difficult to define because disease prognosis really consists of a combination of factors. The activity of the disease and the duration of activity of disease certainly contributes to prognosis in that patients with persistently active disease with multiple joints involved have a poorer prognosis than patients who have very few joints involved with relatively limited disease activity. Also, features such as the presence of circulating rheumatoid factor or circulating anti-citrulline protein antibodies, ACPA, contribute to poor prognosis, and the presence of erosions on a plain radiograph or evidence of erosions on musculoskeletal ultrasound or MR imaging also contribute to demonstration of poor prognosis. So assessing the patient's potential to respond to therapy is essentially what disease prognosis consists of, and one should do that at least once a year. Patients can be treated not only with non-biologic disease-modifying antirheumatic drugs or biological therapies, but also with glucocorticoids. Glucocorticoids have the potential to control inflammation quite rapidly and quite effectively, but have associated with them certain side effects and toxicities that can be quite detrimental if they're used long-term without appropriate prophylactic measures. Patients who are treated with glucocorticoids should have bone density assessed at baseline, and periodically during therapy they should be on bone protection with an anti-resorptive agent and calcium and vitamin D supplementation. And the disease activity should be assessed regularly, and the glucocorticoid dose should be reduced as often as possible so that patients are on the lowest dose of glucocorticoid necessary for the shortest period of time. This PQRS measure number 180 measures the percentage of patients aged 18 years and older with a diagnosis of rheumatoid arthritis who have been assessed for glucocorticoid use, and for those on prolonged doses of prednisone of at least 10 milligrams daily or the equivalent, with improvement or no change in disease activity, documentation of a glucocorticoid management plan should be performed within 12 months. We know that glucocorticoids, especially low-dose glucocorticoids in rheumatoid arthritis, can improve the functional and structural outcome of patients with active disease and are an effective adjunct to disease-modifying antirheumatic drug therapy. So it is appropriate and necessary to manage these drugs safely and carefully to minimize toxicity over time. Well, we've now discussed 6 different PQRS measures related to rheumatoid arthritis, each of which is reasonable to follow in clinical practice, and certainly assessing in a more structured way our compliance with these practice guidelines, so to speak, will lead to better care for the patient and a better overall quality of rheumatology practice among our colleagues. In summary, quality indicators are based on clinical experience and treatment guidelines. quality measures assess compliance with using these quality indicators in clinical practice. And these measures should assess the minimum standard of care that should be provided to patients with rheumatoid arthritis. We've reviewed 6 PQRS measures relevant to rheumatoid arthritis care, each of which assesses something that we're all already doing in clinical practice, and if we're not, something that we should be doing. The quantitation of compliance with these PQRS measures may seem burdensome at first, but provides us with a benchmark whereby we can assess quality of the care that we provide to our patients and should help to improve the outcome of our patients with rheumatoid arthritis. I appreciate the time that you've spent with me reviewing rheumatoid arthritis quality in the value-based care environment, and hope that I've helped to share some thoughts about the evidence behind these rheumatoid arthritis quality measures. I'm Dr. Jonathan Kay. Thank you very much for your attention.